can take any urine, and the catch here is that the urine should be in bladder for at least 4 hours or so, because that's the turnaround time when the bacteria would release the enzyme. If the child is voiding very frequently or a very small baby, then it may sometimes be false negative.
That is for all the tests. But for this, midstream is not required.
No, not midstream is not
And in less
required,
than
not
6 months,
mandatory. And
why-
normally
why
I would
only-
ask for an early morning sample, because the bladder, the urine has been in the bladder overnight. Chances of getting these nitrite and Le positive is much more if the urine has been in the bladder for longer period. Otherwise, if the child comes to my clinic at 12 o'clock, I ask last urine kab kiya tha? Mother says at 8 a.m. Then it is safe enough to take the urine at 12 p.m. also.
in less than 6 months, not only urine but blood culture should also be done.
Depending upon if you are suspecting a sepsis or a systemic disease, then of course blood culture. But if you are having targeting at UTI, if the child has got symptomatology pertaining to UTI and we have Le or nitrite positive, more than 5 WBCs, again our suspicion goes more towards UTI.
Fine. So coming to Dr. Neha, what will be your choice of antibiotics, the route as well as the choice?
So sir very well said that we need to start the treatment early. Now how do we start is, that is the clue here. So nowadays it is recommended that oral route is preferred and advised over IV route. Only in special scenarios where the child is less than 2 months of age, or if he is very sick or unable to take orally, then we go to IV therapy. Also, if you start IV therapy and if the response is seen within 3 to 4 days, it is preferable to switch to oral route of administration. Because there was a study that has been done, and there was not much of significant difference between the resolution of the fever, day 3 fever, recurrence of UTI at 6 months of time, and any kidney damage that was taken over a period of 6 to 12 months. So not much difference was found, and that is why oral is preferred. I'll put one more point over here, that IM route is not advisable in children because the data is very limited. Now about what antibiotics do we select is, the first and foremost is the 3rd generation cephalosporins or coamoxiclav is preferred, IV or oral, whatever, in suspected febrile UTI. If the child is little older, an adolescent just coming with cystitis, then you may choose 1st generation cephalosporins. In that case, that is okay. Now, what we do not choose is cotrimoxazole or nitrofurantoin for therapy, because cotrimoxazole, there was a study that showed that persistent bacteriuria remained even after giving cotrimoxazole for the days that was prescribed. And besides, there is not much of significant difference in the persistent bacteriuria, persistent fever. So it is better to choose 3rd generation cephalosporins.
Now, what should be the duration of antibiotics?
Now,
As per the previous literature, we still supposed to give 14 days, or can we cut it short?
Yeah, so previous literature said that we need to give 14 days of therapy, especially if there is a febrile UTI and along with symptoms. Now the newer guidelines very well clearly have mentioned and reduced the duration of the antibiotics. It is 7 to 10 days in case of acute symptomatic UTI. And if the child is just coming with symptoms of cystitis and a little more older child, we can give up to 3 to 7 days. Again, there was studies that have been done and not much difference was found over a prolonged duration of antibiotic therapy and over a shorter duration. So it is better to complete the therapy within 7 to 10 days of the therapy.
So to summarize, like in case the child has UTI and you're suspecting cystitis, especially in adolescent child, in that scenario, an oral antibiotic of 3 to 7 days is okay. Febrile UTI, pyelonephritis, loin pain, in those scenarios, and child is less than 2 months old, sepsis, renal angle tenderness, poor oral intake, means a sicker variety where you're suspecting upper tract UTIs. Then IV antibiotics for 3 to 4 days. Once the child is able to take orally, shift to oral antibiotics. If that is not the scenario, you can directly jump in for oral antibiotics. Good clinical response, continue the antibiotics for 7 to 10 days. If no, then you may repeat the urine culture and ultrasound. towards the end of therapy, there is no point repeating a urine culture to see whether it's become negative or not. Max, you can see the trend of your urine routine, the pus cells. If there was around 80 pus cells and now it is down to 10, that's good enough, and clinically the resolution of symptoms. You need not vouch in that I want my pus cell to be less than 5 and then only I will stop my therapy.
How long the leukocyte esterase and nitrates be positive?
Ma'am, leukocyte esterase is just suggestive that there is WBC in the urine. So till the time WBCs are there, it may turn out to be positive. Once the WBCs are less, it will turn to be negative. But remember that even 2 to 4 WBCs can still have a leukocyte esterase being positive. So for initial detection, okay, you can do it follow up with leukocyte esterase and nitrite for just to initial pickup. But once you have your culture report in front of you, a urine routine in front of you, the follow up may be just with a urine routine. You need not do dipsticks to check whether things are getting better or not.
If the culture is negative, but nitrates are positive, then does it mean that the infection is persisting? Yes. We don't need to do a culture.
For follow-up scenarios, if clinically the child is getting better, you need not do a nitritis to see what is happening, because you can say the colony counts may be actually on a decreasing trend, but till the time the bug is there, it may still continue to show a nitrite being positive. So leukocyte esterase is just the initial test for the early pickup of the UTI. But once your routine cultures are there, then your follow-up is always on in terms of routine or the clinical scenario. You don't do it with the sticks.
But in the routine test, usually they give the report.
They will give it, but you follow with your urine routine report, well, the pus cells. So Dr. Atanu, what's your call on asymptomatic bacteria?
Yeah, when you have a positive urine culture of a single uropathogen, but there is no symptom. In fact, I think urologists did advise us not to go for a urine culture when there are no symptoms. And prevalence, of course, slightly more in girls. And when age is less than 2 years and there is a phimosis, a lack of circumcision in boys, these are the risk factors. Normally, though, it indicates commensalism, but in older children, we used to, I think Dr. Varinder sir is also here. In TB also, sometimes we thought that asymptomatic bacteriuria would be one of the symptoms. Yeah.
Okay, even if the cultures are positive, everything positive, do not treat them up if the child is asymptomatic. Because otherwise what may happen is, because they are just non-virulent strain which has commensals, so they may get wiped out and you may replace them with virulent strain. Only exception here is if this child is planning to go for any instrumentation. The urologist or the pediatric surgeon is about to take this kid for some kind of surgical procedure, or a post-renal allograft recipient with a allograft age of less than 2 months. These are 2 scenarios where you actually treat them off, but otherwise there is no point treating them. Now coming to Dr. Anjali, so now urine routine cultures, everything has been done, you have initiated the treatment, the child is doing well. Now comes the question of the renal imaging, the ultrasound, the MCU and the DMSA. So what's your take on the ultrasound part, and then you can continue, and when to do the MCU in such children?
So ultrasound should be done in all children who are presenting with the episode of urinary tract infection. It helps us in a lot of ways. It tells us about the kidney sizes, the presence of hydroureteronephrosis, the bladder, the volume, the bladder wall thickness. So a lot of information can be taken from a simple test, which is an ultrasonography. It can be done at any time after an episode of UTI, but only when the child is not improving during the treatment of UTI. Even after 48 hours of an appropriate antibiotic therapy, we suggest doing an ultrasound at that point. Otherwise, it can be done at any time after an episode of urinary tract infection.
So nowadays we have this high resolution ultrasonographies which can even pick up a scar while doing the ultrasound. So it may give you a hint of a scar, but final is once DMSA is done. I still have 7 minutes, I think. 2 minutes. It's showing 7 minutes.
So indication of an
So in
MCU.
MCU, when to do?
So there are only 3 indications currently as per the current guidelines in any recurrent episodes of UTI, or in a non-E. coli UTI in a children less than 2 years of age, or any ultrasound abnormality in the form of any hydronephrosis or bladder wall thickness or a significant post-void residue, you can go for an micturating cystourethrogram. It can be done anytime after the treatment of urinary tract infection.
So these are a couple of MCUs. This is a normal bladder with the normal posterior urethra, anterior urethra. Here you can see the reflux. Here along with the reflux there is a uretrocele which is seen. This is a dilated posterior urethra in a child with PUV, and this is a trabeculated bladder in a child with neurogenic bladder. So coming to Dr. Neha, so what's your take on DMSA scan? When to do, and when in the sense whether to do it in the acute phase or should we wait for 4 to 6 months and then do it?
So the newer guidelines have very clearly mentioned that there is no role of acute phase, that is less than 2 weeks of time of UTI. There is no role of acute phase DMSA because one, DMSA does not increases the yield of MCU while to diagnose VUR. Second, it has very poor specificity, and the long-term outcome of a UTI is a renal scarring. So that is not detected in an acute phase DMSA. Plus the cost and the radiation is also another factor that we have to take in. So nowadays what we recommend is after 4 to 6 months of a febrile UTI, we go ahead for DMSA to look out for the scarring, renal scarring.
Fine. So this is a normal DMSA scan. Here you see a scar. There is loss of cortical volume. So this is a scar which is going to remain lifelong with this child. But this is an acute phase DMSA which just shows a photopenic defect. Now this may heal off completely or partially. So what we are interested in is long-term damage. That's why we do a DMSA only after 4 to 6 months. So Dr.